So now we're going to move from anti-inflammatories into antibacterial agents. And the first ones we're going to talk about is the beta-lactam antibiotics. For the objectives for this chapter, we're going to learn about the general characteristics of the beta-lactam antibiotics. We're going to talk about penicillins in relation to its effectiveness, the safety, the spectrum of their antibacterial activity, how they work, which is a mechanism of actions, when is that it is indicated to be used, how to administer them, and also observations on the patient response and teaching to the patients. We're also going to emphasize the importance, guys, of questioning patients about the allergies before we start any drugs, especially penicillins. We're going to also discuss the characteristics of beta-lactamase inhibitor drugs. We're going to talk about the rationale for combining a penicillin with a beta-lactamase inhibitor drug. We're going to talk about cephalosporins, carbapenems, and the monobactam in relation to effectiveness, safety, their spectrum of activity, mechanism of action, indications for use, administration, observation of the patient response, and the teaching. And we're also going to implement the nursing process when caring for patients receiving beta-lactam antibacterials. We have a few terms for this lecture, and the first one I want to discuss with you is beta-lactamase. This is an enzyme that's produced by some bacteria, and this it's going to attack the beta-lactam ring. So mainly beta-lactam antibiotics have a structure that it's called a beta-lactam ring, and that's necessary. That's essential in order for the antibiotic to work. So the beta-lactamase, it's produced by the bacteria in order to disable the antibiotic by messing up with the beta-lactam ring. So in that sense, then now the antibiotic, it's not going to be able to work. And then we also have cross-allergenicity, and this is an allergy to a drug of another class with similar chemical structure. Also, we have extended spectrum, and this is antibiotics or bactericidal activity that can actually work for a wide range of bacteria. And superinfection, which is an infection on top of the previous infection mainly, and it's usually caused by resistant bacteria. Okay, guys, so the name, it's derived from the beta-lactam ring, and we already talked about it, right? It's an essential structure for the antibacterial activity. And when enzymes can actually disrupt the ring, they can actually grow resistance. And that's how bacteria works. They have developed specific enzymes to destruct the ring, and those and that's called the beta-lactamase. So this class is going to include the penicillins, the cephalosporins, the carbapenems, and the monobactams. So penicillins are safe, effective, widely used, first antibiotic developed from the penicillin mold. At first, these medications have to be given parenterally or through injections, since it was destroyed by gastric acid. Injections were painful and still are painful. Semi-synthetic drug derivatives have to be developed in order to increase the stability of penicillin and the spectrum. So by doing so, then the drug was made available through different routes. Now, the extensive use of the persistent use of these medication is going to create a resistance. So these microorganisms are going to develop a resistance to the drug. And one of those is the staphylococci. Now, post-absorption, the medication is widely distributed. I forgot to mention the ampicillin is a prototype for these class, and we can achieve therapeutic concentration in most body fluids. Now, it will not penetrate the cerebrospinal fluid unless there is inflammation of the meninges, okay? That's the only way. This med is going to be excreted very fast by the kidneys, and it's mainly unchanged excretion. So it's going to produce high drug concentrations in the urine. This med is going to be present in the breast milk, and then the volume of distribution is going to increase during pregnancy. Okay, so this ampicillin is gonna work by inhibiting bacterial cell wall synthesis. So mainly that's how penicillins work. They're going to inhibit the synthesis of the cell wall of the bacteria, and by doing that, mainly they're destroying the bacteria. Now, the indications for use, it's going to be bacterial infections caused by susceptible organisms. They're going to be more effective against gram-positive than gram-negative infections. They're used for skin, soft tissue, respiratory, GI, and GU, that's gastrointestinal and genitourinary infections. But the incidence of resistance continue to increase. So bacteria becomes smarter and they become more resistant. Now the contraindications for use is of course hypersensitivity or allergic reaction to any penicillin. There is a potential of cross allergies or allergenicity with cephalosporins and carbapenems. So when patients have developed life-threatening allergic reactions to penicillin, then we do not use cephalosporins and then we do not use carbapenems. That's why it becomes so important to ask about allergies, specifically to penicillin, if we're going to give a cephalosporin or a carbapenem, and we're going to learn the names of those a little bit more right now. But we always ask purposely, do you have an allergy to penicillin? If they say yes, then you ask what happened. Well, I get anaphylaxis. Then no cephalosporins, no carbapenem for that patient. Now, extended spectrum penicillins. This is the broad spectrum antibiotics, and we mentioned that they can work against gram-negative organisms. They can be used for urinary tract infections, prostatitis actually, and they can be given intravenously and also IM. Now, we also have some medication combinations, and those are the penicillin beta-lactamase inhibitor combinations. We said the beta-lactamase is that mechanism, is the enzyme that bacteria have developed in order to disrupt the penicillin beta-lactam ring, which is essential for penicillin to work. So, or not only penicillin, but the beta-lactam bacteria. So we have inhibitors, and when penicillin is combined with the beta-lactam inhibitor, then now we have a mechanism of defense against the bacteria resistance. So by very little antibacterial activity, they're going to bind and inactivate the beta-lactamase, and it's going to protect penicillin from destruction. It's going to extend the penicillin's efficacy. And then they may be effective in bacterial infections that are resistant to a beta-lactam antibiotic alone. So this is where an aid comes right into help. So we can see the beta-lactamase inhibitor as like the sidekick of penicillin, coming and helping penicillin destroy the bacteria, right? So if you think about it that way, you'll remember that the combination is needed in order to destroy bacteria that have developed some resistance to penicillin. Now we have the cephalosporins, guys, and these are also derived from a fungus. They're also very used. It is, again, a broad spectrum antibiotic, and I know you keep hearing me saying broad spectrum. I know I have already explained these before, but broad spectrum antibiotics, they're antibiotics that can be used for different organisms, like more than one or two or three. Like they have a broader range of killing capacity mainly, and they're good up to a point because if a patient comes with let's say pneumonia, and the hospital only has certain time to follow the pneumonia protocol, and we have to collect a culture right away, even before giving any antibiotics. So then we collect the culture to send to the lab to try to know what's the bacteria causing that pneumonia. And then we start a broad spectrum antibiotic because we don't want to waste time and we want to start killing whatever it is as soon as possible. And then after the culture and sensitivity results come back, then that's when we know exactly what's the organism causing the infection. And also the sensitivity test is done in the lab to know which antibiotic kills that specific organism in a more effective way. So that then is when the antibiotic is switched to something that's more narrow, just more specific to that organism. So that's what broad spectrum and narrow spectrum is. So cephalosporins have a broad spectrum bactericidal activity against gram positive and gram negative. They're more active against gram negative when you compare them to the penicillin. So if you compare cephalosporins and ampicillin, ampicillin is going to be a better antibiotic for gram positive, and cephalosporins is going to work better for gram negative. Again, it's going to be distributed into most body fluids and tissues. The maximum concentration is going to be in the liver and kidneys. So that should give us a red flag right away, right? If we have patients with renal failure and liver failure. And there is 5 subgroups or generations, and these are based on the pharmacology and the spectrum of activity. Okay, so why do we use them? What are the indications to use? They can be used as surgical prophylaxis. If we go back to our book, our patient in the book, our case has, it's going to have surgery and he's being prescribed an antibiotic. He's being prescribed, I think, cefazolin, and that's before the procedure. So that's a prophylaxis. They're also used for the treatment of infections when the infection is already going on, right? Either respiratory tract, urinary tract infections, skin, soft tissues, bones, joints, brain, spinal cord, and septicemia. Now, if we pay attention to the difference, these cephalosporins can be actually used for the brain and the spinal cord. The ampicillin would only, or the penicillins would only penetrate the CSF or the cerebral spinal fluid if there is inflammation. Okay, so contraindications. Of course, any anaphylactic reaction to penicillin. Remember, we ask about that. And also if they have an allergy to cephalosporins. We have the carbapenems as well, and those are broad spectrum. They're bactericidal beta-lactam antimicrobials, again, and they're going to work the same way. They're going to inhibit the synthesis of the bacterial cell wall by binding with the penicillin binding proteins. In other words, they're just going to prevent mainly the development of these of bacteria. They're going to inhibit the growth and the multiplication. This group is going to consist of 4 drugs. The prototype for this class, guys, is the imipenem cytostatin. This one may be used in children, but not when CNS infections are present, because there is a risk for seizures. Now, for the elderly, renal, hepatic, and critical illness patients, lower doses may be necessary, and also we need to pay attention to other medications that the patients are taking. Now, there is a potential, again, for cross-reactivity or cross-sensitivity with patients that have severe allergies to penicillin. Okay, so now we have the monobactam, and this class is active against gram-negative bacteria. Remember that penicillins are mainly active against gram-positive bacteria. And guys, this could be a kind of an advantage, because remember that normal flora that we have in our body. So by monobactam being active only against gram-negative bacteria, it's at least going to leave alone like the normal flora that we have. This medication is also going to be active against many of the resistant strains of bacteria. It does not cause kidney damage or hearing loss, as we're going to see with the aminoglycosides, who could cause nephrotoxicity or ototoxicity, auto referring to the ear. And the indications for use for these medications are going to be urinary tract infections, skin structures, and of course the skin, lower respiratory tract infections, intra-abdominal. We also have gynecologic infections and septicemia. Now, guys, when I mentioned that the drug can be distributed to almost any tissue, and I have mentioned this before, I just want you to understand that if the drug can actually achieve getting into different tissues, that means that it could work in those tissues, okay? Now, I know I have mentioned that about the normal flora. One of the things is that could be an advantage, but also being that this drug does not work for gram-positive bacteria could be a disadvantage, right? So it's not meant to be used for gram-positive bacteria. So again, that's why the culture is so important, because what if the organism that's causing the infection is actually gram-positive? It can be stained with a gram stain, and the person is taking this medication in monobactam, which is only effective against gram-negative bacteria, so the infection is not going to go away. So that's how it is so important that we put together all of these concepts of the culture, the sensitivity, the gram-positive, the gram-negative, and how they work, right? Okay, guys, so let's move on into our next slide. If there is anything else we need to mention, then we'll do it during lecture. So why do we use antimicrobials? Of course, to prevent infections and also to get rid of infections. So the drug selection is going to depend on the organism. Remember, depending on if it is gram-positive, gram-negative, can Can it be killed with penicillin or not? With ampicillin, with a cephalosporin? The severity of the infection as well. Is it an infection that can be taken care of with oral medications? Can the patient go home and just take their medications orally every day? Or it is so severe that it requires IV antibiotics? Or can the patient really remember to take the medication, or is it better to give him an injection that's going to be long acting? So, and we need to consider other factors such as the patient's circumstances, right? Is it an adult? Is it an elderly patient? Is it a kid? Is it a pregnant lady? So all of that is going to have to do with the drug selection. And also the use in special populations, I kind of already mentioned. Renal impairment, hepatic impairment, older adults, children, pregnant ladies, perioperative use, right? Such as like the cefazolin, which is actually the prototype for the cephalosporins for prophylaxis, and also home care.